Before I start, I'd like to thank the organizers, Dr. Prachi, for the invitation to share some thoughts with you this afternoon. I I feel a little bit apprehensive. I'm the odd man out of this team today speaking to you. Everyone feels right at home. I'm the guest. So, all right. The title of the presentation is Optimal Use of Protein for Better Outcomes in Critical Illness. But it may well be that the title will more appropriately be not just protein, but actually the whole of nutrition therapy, because it is not just protein which we look to for the benefits that we look for in critically ill patients. It's very interesting to look at this recent publication. This is from Professor Argiles from Spain, published just last year, which looks at metabolism in the fed state comparing with the fasted state, where in the fed state you can see that the nutrients go to the organs which require the nutrients, and if feeding is not received by the individuals, then in the fasted state, from the storage forms, you can see that the nutrients are now utilized by whole or for whole body metabolism. I think this is clearly understood. But now we look at the topic of the day, which is what about the malnourished state, and what about in particular the malnourished state where patients are critically ill. And here you see, proceeding from this diagram, from a state of fasting, you now come to a state where the individual is eating up his own skeletal muscle to provide for tissue structure and function, organ structure and function, immune responses, skin integrity, wound healing included, and neural function. And you can see that this storage form, which is skeletal muscle, is not endless. It is finite. It is limited. And therefore, we need to come to a realization that we need to prevent the utilization of skeletal muscle and instead provide exogenous protein. But protein is not magic. Just giving protein will not execute the wonders required. You need to give protein within the context of a full nutrition therapy regimen. That is the only way it will work. And why is this? You can see the catabolic consequences of stress and injury reflected here, where an interaction of stimuli along the hypothalamic pituitary axis, which has been mentioned in the previous lecture, will result in an interplay between cytokines and the sympathetic nervous system to give rise to mediators that will result in mobilization of energy reserves. This will be the liver releasing or breaking down liver glycogen to give you glucose. But this supply is limited, and after a while, the body will turn to breakdown of lipids lipolysis to provide glucose for gluconeogenesis. This will result in a transient hyperglycemia. But the neuroendocrine response, the hormones of stress, will prevent further utilization of lipids. And now you will see that if no nutrition is provided, what has to happen to ensure continuing gluconeogenesis, a continuous breakdown of resources that come from the muscle, resulting in a whole body protein catabolism. This has to be understood very clearly, because if you take a closer look at the arm, you will see that the catabolism results in a breakdown, literally, so that amino acids are released. And here you can see very important amino acids, glutamine and alanine glutamine. And for those of you in the back, I have enlarged this so you can see very clearly that in the amino acid efflux that ensues, you have this situation coming about. What does it mean in clinical terms? It means, and the group of Zudin Putuchari from London and his team have shown very clearly in New England Journal of Medicine, the concept of acute skeletal muscle wasting in critical illness, where on the first day in ICU, you see individual patients with healthy muscle And just a week later, despite all the best treatments the patients can get, by day 7, you see necrosis and cellular infiltrate. What does this mean? We talked about cases earlier. What does it mean for an actual patient? It means something like this. Some of you may know Professor Paul Wishmeyer. He used to work at the University of Colorado. He has now moved to Duke, a very prolific writer in critical care and in clinical nutrition. In July of 2014, he underwent emergency laparotomy. And within 20 days in ICU, he reports a loss of muscle mass of approximately 1 kilogram of muscle per day. And the loss of weight and loss of muscle is 20 kilos over 20 days. Is it remarkable? Of course, he has a lot more muscle than some of us do. So you can see that he would have more to lose. Thing about this muscle loss is that in critical illness, we lose muscle faster from the diaphragm than we do from other core muscles. And as you can see from this study, loss of muscle from the diaphragm, as shown in these pictures, was greater, and the rate and amount was greater than loss from the psoas muscle, which represents the core muscles. It's a remarkable loss. And this has an implication for patients on ventilator support. Because when you have patients on ventilator support, this Dutch study showed that looking at the patient from day 1 of mechanical ventilation and moving on 1 week later, you can see that the muscle has deteriorated. And in fact, the diaphragm muscle thickness as measured by ultrasound has decreased over the first week of ICU care. And the implication would be, despite best ventilatory management efforts, how difficult would it be to wean a patient with no respiratory musculature? And this ties up with actual outcomes, because there is a quantification of loss of lean body mass as shown here and corresponding associated complications. Just 10% loss results in decreased immunity, increased risk of infection. 20% you have problems with wound healing, muscle weakness, and this becomes the basis for what later develops into ICU-acquired muscle weakness, which persists weeks, months, even years following discharge alive from ICU. 30%, you start to get pneumonia, inability to heal, and 40%, the patient will invariably die, most likely from pneumonia. It is a grim picture, but it is true. And the other thing that matters is it's not only the amount of muscle, it's not just muscle mass, but also muscle quality. What this study shows, this is a study that looked at mechanically ventilated ICU patients. This is a study in surgical patients undergoing pancreatic major surgery for cancer. You can see the top graphs indicate that patients who had poor muscle mass quantity had poorer survival, but beyond that, patients who had poor muscle quality, this was also associated with poorer survival. Does this have an implication for healthcare costs? It certainly does. And in fact, what you can see from this graph is that the patients depicted in gray are the patients with sarcopenia, had an associated higher cost of care than corresponding patients who did not have sarcopenia. And this translates further to such an implication that as you see the increasing loss of muscle mass or sarcopenia, you can see an increasing cost of care as well. So it is a condition which requires some intervention, and the intervention must begin while the patient is with us in ICU. And I mean literally still with us, because as you saw, if we allow this loss of muscle mass to persist beyond 40%, then the patient is no longer with us. And the intervention, therefore, would necessarily imply the need for nutrition. And the need for nutrition has been clearly proven in formulations with essential amino acids, branched chain amino acids. Some early studies have promising concepts about HMB, But the other important thing, which has also been mentioned in the previous talk, is the importance of muscle activation, because muscle exercise, resistance training, provides a stimulus for protein synthesis. And here you see the collaboration between multidisciplines, so that feeding the patient and exercising the patient can result in the best use of the nutrition. So let's focus then on nutrition. It's not my task today to talk about the exercise. Just a reminder, we've been sitting here all day. Maybe consider some later. All right. If we feed patients appropriately, this is a study taken from a bigger study of ICU patients, and this study focused on a group of ICU patients, some 400 or so patients staying in ICU for more than 2 weeks on ventilator support. And what it showed was, if patients received up to 80% or more of their nutritional requirements, their survival was much better than patients who received 50 to 80 or even less than 50% of their requirements. And the implication in terms of what I've just told you is that this nutritional adequacy was associated with an improved 6-month survival and physical recovery, meaning muscle strength, 3 months post-ICU discharge, and this correlated with each 25% increase in nutritional adequacy. So that tells us when nutrition is adequate, then we make headway in patient care. The other aspect is this. Previously, we always thought that calories were so important. The trend today, and I've just come from the European Society of Parenteral and Enteral Nutrition meeting, is today to look at muscle and to look at protein. And the importance of protein, as shown in this study by Peter Weiss and his group from the Netherlands, is that in critically ill ventilated patients, reaching both protein and energy targets results in a better mortality hazard ratio, which is shown here. The lower you go, the better, means lower mortality. And energy target reached is ET, protein and energy target reached is PET. And what this shows us is, if you reach energy targets alone, this is how much your mortality hazard ratio is. But if you reach together with energy protein targets as well, then you lower that even more. And in fact, in this best model, where you see the lowest mortality hazard ratio, it is in a group of patients where the model is adjusted for time to energy target. In other words, if we say let's feed the patient, but let's feed the patient after a week, doesn't work. You need to feed early. Time to energy target, and obviously in critically ill patients where it's difficult to feed with enteral nutrition, you need to consider reaching the target might entail the use of parenteral nutrition. Okay. Another study. This is an awarded paper from the American Society of Parenteral and Enteral Nutrition, 2015, which shows, again, the importance of adequate energy and especially highlighting protein related to protein delivery, showing once again here that greater protein intake, indicated by the arrows, is associated with a lower mortality. And in fact, if we are able to reach at least 80% of the prescribed protein intake, this is the level at which it begins to make or it begins to matter for patients. The other aspect which is shown in previous studies is this. If you increase caloric adequacy, you get better to a point. As you see here, this is mortality rate. But as you reach 100%, close to 100%, and you keep going, then the mortality starts to increase again. What does this tell us? That overfeeding calories is harmful. But the other aspect is this. If you increase protein intake as you move along, you can see that mortality rate continues to improve. There is no U-shaped curve. As you increase protein, the patient's outcomes improve. And what is the level or target of protein to reach, therefore? It should be around 1.5, top level. around 1.5 grams per kilo per day. And this is now the recommended level in the European guidelines. There are not many commercial EN or PN solutions that allow reaching this high target, but what has been found is that if you're striving for the goal of up to 1.5 grams per kilo, this Swedish paper from Olaf Ryakers and this group, together with Professor Jan Wernerman, has shown that you can actually use glutamine, whether IV or enteral glutamine, to enhance the protein content as shown in this particular model of increasing protein intake. All right, let's shift gears briefly now to look at how to deliver nutrition. And that needs to be in a context which is acceptable to both the surgical community, represented in this paper by Professor Arvid Weimann, the lead author for the new European guidelines in surgery, and Professor Thomas Felbinger, who also is on the guideline group for the ICU part of it. And what this shows is when patients require nutrition therapy with no contraindication to EN, then they should start enteral nutrition at a slow rate, progress enteral nutrition, and as you start ramping up the enteral nutrition intake, you need to assess, is the patient malnourished, pre-existing malnourished? Is the patient at risk for malnutrition? More important, is the patient at risk for complications related to malnutrition? Wound dehiscence, anastomotic leak, things like this. And if your patient is malnourished or high risk, if you answer yes, then it is imperative to reach goal of calories and protein by day 3 to 4. Day 3 to 4. There have been other studies that suggested that feeding in the first week may be harmful. Day 3 to 4, you need to reach your goal. I will explain a little bit more as we go along. But if the patient is not at high risk, and this is why screening and assessment is important, then if not at high risk, then you can wait later. But high-risk patients who have problems reaching their goal with enteral nutrition should consider supplemental PN by day 3 to 4. And the reason for this time frame is shown on this slide, which shows you on the first curve, it shows you the total energy expenditure in patients. In the second curve, it shows you endogenous energy production. What is endogenous energy production? It's the energy that comes from glucose that results from glycogenolysis and gluconeogenesis in this metabolic response, which I showed you earlier. And what you can see is there is a gap between what is required and what is available. And that gap can be filled by the early ramping up of enteral nutrition. But as you can see, the gap between required energy and existing energy increases from day 3 to 4. And therefore, if we rely on early EN alone, then we are at high risk for underfeeding without PN. And this underlines the importance to consider supplemental PN. Because without supplemental PN, you have a high risk of underfeeding. And this high risk of underfeeding, I already explained to you, is related to problems with survival, etc. Whole body protein catabolism. All right. Can I ask, show of hands, how many of you are able to feed EN to your critically ill patients up to 80% by day 3? This is good because I like this comment, not all, because patients who are critically ill, and I mean really critically ill, difficult. Why? Because it is their particular state of critical illness in which GI dysfunction becomes correlated. In fact, the GI failure trial group of the European Society of Intensive Care Medicine, which is starting to meet today in Vienna, shows us a review that indicates that as patients have more than 3 GI symptoms, you can consider that they will have a poorer outcome than patients who have less than 3 GI symptoms, where the GI symptoms mirror the seriousness of their critical illness. I look at this as a kind of gauge for the presence of gut failure. If you want to look for renal failure, you think about maybe serum creatinine, maybe clearance, etc. If you want to look for cardiac failure, you look to other electrophysiologic phenomena, etc. But when you look for signs of gut failure, is there a marker? Can you take a blood exam and say, you have GI failure? No. You can only tell it from the patient's failure to progress with enteral nutrition. And in fact, what recent studies show us is that when patients really have GI dysfunction progressing or rather deteriorating into failure, this failure will eventually involve other organs and become a cascade in the multi-organ cascade failure, or the multi-organ failure cascade, rather. So this highlights what is today published as the 2017 Guidelines of the European Society of Intensive Care Medicine, Clinical Practice Guidelines for Early Enteral Nutrition in Critically Ill Patients. They recognize there are certain parameters in when patients have them, you don't force to feed them because it could be unproductive. And here you have patients who have increasing GRVs, bowel ischemia, bowel obstruction, etc., down the line. And when you have patients with this condition who are previously malnourished or at risk for malnutrition complications, then it becomes important to feed. And in the presence of contraindications to enteral nutrition, then we find these are the indications to supplemental parenteral nutrition. Early enteral nutrition offers non-nutritional benefits, no doubt, and therefore we should always go for early EN. But you can see that there are multiple non-nutritional responses associated. Please look at the color coding, blue, green, and red. I will come back to this as we go along, because in patients who cannot receive enteral nutrition for whatever contraindication, glutamine IV in PN has been shown to provide some of the benefits associated with these non-nutritional benefits of EN. In fact, that has been shown here. These are the glutamine benefits, the mechanisms of action. And you can see, I told you to remember the color coding of blue, green, and red. You find that these are some of the benefits that are conferred by delivery of early enteral nutrition. All right. For those of you who have read publications where the safety of parenteral nutrition has been questioned, there are now recent randomized trials that support use of early PN. You have the Swiss trial, the ANZIX trial, 31 ICUs. You have the Calories trial, which is definitive multi-center trial from the NHS in the UK, 33 ICUs, showing no difference between EN and PN outcomes. And previously, the United States has been hesitant with the use of parenteral nutrition because of their expertise with enteral nutrition. Paul Wishmeyer and his group has recently published the pilot results of his top-up trial, which is a supplemental PN trial that looks optimistic for the delivery of PN. And there's clearly not much difference today perceived in the different benefits between EN and PN. And as this new meta-analysis shows us, if we keep calorie provision similar, there are no significant differences between the routes, indicating that where EN is desirable because of its non-nutritional benefits, whenever not suitable or contraindicated, then it's fine to go to supplemental PN. And as the 2016 ASPEN SCCM guidelines show, this is the progression that I've taken you through, using EN preferentially, and when EN is not enough at the end, to start parenteral nutrition. I will show you my concluding slide, which is a summary of what I've tried to share with you. First of all, muscle catabolism with its included proteolysis is today considered as a primary serious consequence of critical illness, persisting way beyond discharge, even alive from ICU. That adequate protein delivery as part of a full nutrition regimen needs to be considered, has an important role in delivering nutrition. Early EN is, of course, the first choice. I've tried to convince you of that, but whenever EN is not enough because of problems with poor tolerance associated with the GI dysfunction of critical illness, then early supplemental PN needs to be turned to without hesitation. Specialized nutrients like glutamine and omega-3 fatty acids are important to maximize efficacy, and exercise or muscle training also needs to be included. I will just have 2 slides left, and these are to show that among the clinical evidence for glutamine, there's an important one associated with our particular application this afternoon, which is the improvement of nitrogen balance and protein metabolism, important for building up for protein anabolism. And for omega-3 fatty acids, among the other important benefits from omega-3 fatty acids, you also see preservation of lean muscle mass as one of them. And I close with this. Thank you very much for your attention and for the opportunity.